So I'm going to be talking about, keeping on the same theme with corneal transplantation, about liquid keratoplasty. So these are my financial disclosures. So it's been over 115 years since the first corneal transplantation was performed in Europe by Edward Ziemer. And mainly the procedure hasn't really changed a lot over really that time period. And despite the fact there's been improvements in surgical technique, the full thickness transplantation of the cornea became the hallmark for the way corneal transplantation was performed. If you look at data from the Eye Bank Association of America, you'll still see, regardless of the fact that we're doing a lot more endothelial keratoplasty surgery and it's becoming the most dominant procedure, there is still a significant amount of full thickness penetrating keratoplasty performed not only in the US, but basically also around the world. And the key fundamental part of the keratoplasty procedure is actually the vertical trephination. Over the decades, we've seen an evolution in trephination from no suction trephines like the Solan you can see on the left-hand side over here, that are good to use in cases of perforations or Descemetor also cases in which there may be no undercutting of the edge of the tissue itself. But there can be problems with centrations and often getting issues with getting around trephination with these kind of trephines. Suction trephines became more popular. They were fast to basically cut, but they can cause raised intraocular pressure inside the eye and undercutting the edge of the tissue while they're doing the trephination. Centration can be a problem, and often you get a donor-recipient mismatch with both these trephinations. And this is what I mean by the mismatch that you will get, since the donor is cut from the endothelial surface and the recipient is cut from the epithelial surface. So often you'll get a matching on the anterior surface, but you will get a gap over here on the posterior surface when you're basically doing your suturing. So the thought has always been that if we could induce the femtosecond laser into this technology, we may be able to improve on some of these things by removing or reducing the amount of undercutting of the edge. Can we keep the IOP a bit more stable inside the eye? The femtosecond laser should allow us to do different shapes. And of course, we can cut the donor and the recipient both basically from the same side. So we can cut it from the endothelial side up towards the epithelium. So we should be able to get a much better matching of our transplantation procedure. So a few years back, we published this paper in IOVS back in 2012, where we actually looked at the effect of the intraocular pressure in a rabbit eye, and we used this rabbit manometer in the anterior chamber to check the intraocular pressure. And we compared a femtosecond laser to that basically measurement using a manual trephination. And what you can see is if you look at the red line over here in the manual, you see during the manual cutting, the IOP can actually rise quite sharply, and it can be all over the place compared to basically when the suction is on. And this is because you're getting a prolapse of tissue as you're basically doing the cutting into the obturator. But with the femtosecond laser, this is actually much, much more stable. If you look at the endothelial cell damage around the margin of where you cut, so this would be example cutting basically the donor tissue, you can see with the femtosecond laser, you get very little damage to the endothelium and a much cleaner cut. While with the manual trephination, you get a much more significant damage around the endothelium itself. And if you look at this in a real quantity terms of number of cells, you get about loss of 4,000 cells with the femtosecond laser, but almost between 13,000 to 18,000 cells with the manual trephination margin. When you look at the undercut, the way you basically measure this is by looking at the distance between the anterior epithelium to the endothelium down in basically a straight line. And this area over here, you can see in the manual trephination, is what we basically call the undercut edge. And you can measure this angle. And what you can see is that you have a much reduction in the undercutting edge with the femtosecond laser, only 16.7 degrees, versus a typical manual trephination, which is almost 46.8 degrees of undercutting. And that's because you've got this prolapse of tissue into the obturator during the cutting as well. When we looked at inflammation, when you're comparing the femtosecond laser to trephination, you will see that you do get more inflammation around the wound healing edge of the grass-host junction. So you do get more early wound healing with the femtosecond laser compared to manual, and this will normally settle down after a few days of basically using steroids. So subsequently after this, we started a clinical study where we were using basically the laser. This was published in 2008. And subsequently after that, there have been a whole lot of papers published in the literature that have shown the safety and efficacy of basically doing femto PK studies. Now, if you look at the studies, you'll see that it's been color-coded here in blue and also in orange. The blue studies are studies that have been done using a laser that uses a flat applanator, and the ones in orange have been done basically with ones that have been using a curved applanator. The thinking has always been is that if you use a curved applanator, you get less compression on the cornea when you're actually doing the cutting. But in fact, this is not actually true, because you can see from this diagram over here when you're using a flat applanator versus a curved applanator, because it's a fixed curvature of the applanating surface. When you compress the cornea, you're going to get compression on the surface. And in fact, if you do OCT in human eyes, you will see these little folds if you're using a curved applanator, because of course the K reading is already fixed, and we all know that the K readings will vary in basically patients, and you will get these little folds on the posterior edge of the cornea following your curved interface. And of course, these will be more prominent basically if you have a flap interface. So if you want to avoid these folds to get a nicer, smoother cut on Descemet's membrane, there's only basically one way to do this, and this is basically using a liquid applanation. Now, using a liquid applanation system, there's a video showing over here of this happening in a pig's eye. You will see that, of course, the laser cutting is basically, there's a gap here and there's liquid on the curvature of the cornea. So basically, it takes the issue of the curvature of the cornea out of play. And if you do an OCT, you'll get a much smoother surface, like you can see in this diagram over here. As Gerald basically mentioned, the OCT software, the intraoperative OCT software, allows you to take 8 sections around the cornea to allow you to look at all the angles of the cornea before cutting your vertical rim cut. So you know exactly where you're basically placing on the surface, and you don't get these folds on the cornea like I showed you on the previous videos. So we wanted to study this, comparing it to the flat applanator with respect to different energy settings, with respect to intraocular pressure. And what you can see is, in this study, is that you can see there's less intraocular pressure variation with a liquid applanator compared to the flat applanator. And this is regardless of the energy we use, 150 all the way down to basically 30. The second point is that the liquid applanator actually showed very similar readings to intraocular pressure to what we've previously published using a curved applanating system. But of course, the big advantage of this is that there's no folds on the cornea. If you look at the endothelial cell loss, interestingly, if you look at 90% energy, the amount of damage to the endothelium around the edge of the cut is very similar between the liquid and the flat applanator. But when you increase the energy to 150%, which you may want to do in quite edematous corneas that are quite swollen, you can see there's significantly less endothelial cell damage in the liquid applanator compared to the 150. And in fact, there's no significant difference in the amount of endothelial damage whether you use 90 or basically 150 energy in the liquid applanation compared to basically the flat applanation. So how can we apply this to basically clinical practice? So here's a patient of mine. She's a 71-year-old lady. She has a whole herpes scar over here. She's been inactive for quite some time. Her visual acuity is basically 6/190. So you can see quite dense scar over here. On the OCT, you can see the actual scarring is actually quite deep. Now, people may basically opt to do a penetrating keratoplasty, but you can see some vessels over here. So you know it'll be quite a high-risk procedure. So in these cases, I still would elect to basically do a dog procedure. So I did a manual dog for her, which is a layer-on-layer dissection. But sometimes what happens in these old herpes scars, the deeper you go down, you often get to an area where they actually get fixed folds. And you can see these folds over here only became apparent when I was doing the surgery because you can't see them preoperatively. So I dissected down to 50 microns to basically leave these folds here. Otherwise, you definitely basically rupture Descemet's membrane. Now, visual acuity improved to 624. She was reasonably happy, but I thought, you know, we could probably do something better with this to try to get rid of these folds for her. And this is basically what we did. So what we did is that we removed the bit of the dot using the Femtosecond laser liquid keratoplasty module inside the eye and using the real-time intraoperative OCT to judge our depth of about 75 to 80 microns. So we can cut the lamellar tissue from basically the inside. So the advantage of the scan is you can actually do this real time so you know exactly the thickness of the stroma. Once you've done this basically on the patient using the liquid interface, the scan will go all the way around and it will fire upwards, basically cutting within to the dog up to about 80 basically microns of tissue. Once it's cut, you can simply go around with a simple Sinski hook. So you can see there's a little bit of adhesion there where the previous sutures are, and you can remove the tissue. And once you basically remove the tissue, you can see the scar on the stromal tissue. And then I did a DMEC in the gap of where I'd moved basically the stromal tissue itself. So I replaced the endothelium in the central area. And the tricky thing about the DMEC, of course, you have to get it in that space that you've just created with the Femtosecond laser, basically for your vertical cut. So once the DMEC is in place, which you can hold, you can basically seal it in place with an air bubble. So this is what she basically looked like. So this was basically 690 pre-op. This is 624 after her basically post-operative time period, after her DOLC. This is basically 1 day after her DMEC. You can still see the gas inside the eye. And this is basically what she's like now, 6 months post-op. Gets pretty good visual acuity, and you can see nicely on the OCT where we remove all the scarring, and she's got a new endothelium now, basically from her DMEC. So in summary, femtosecond PK has several advantages over conventional penetrating keratoplasty surgery. You do get earlier wound healing because you get improvement in the wound healing response around the edge of the graft-host junction. You can remove your sutures earlier. There are various graft edge profiles you can use instead of just using perpendicular ones. You can basically use mushroom ones, and you can get a better alignment of not only the anterior surface, but as well as the posterior surface as well. The Z8 liquid keratoplasty module, I think, allows real-time intraoperative adjustment of that rim cut that you can cut. The 8 scans will improve your precision, as I showed you in our clinical example around the whole cornea. You get less damage to the donor rim, and also, of course, the recipient tissue, especially at high energy, which you need to do, especially if you're cutting through edematous, basically corneal tissue. And with the liquid interface, you get no folds from compression as you get basically with curved and basically flat applanating surface as well. The lower IOP can be important because sometimes these patients, especially if they're more complicated, may have glaucoma, and it's certainly a lot lower than using a flat applanator. And you can use the system for simple penetrating keratoplasty cases, but also more complicated cases like I showed you in the example. Thank you for your attention.